Please put your hands together and welcome Dr. Michelle Kittleson to speak to us about update in heart failure management.
Hi, good morning. I'm so excited to be here. Dr. Kim Williams is a really hard act to follow, and I'm already throwing away my ham sandwich I packed for lunch. And I'm just thrilled to talk to you about an update in heart failure management. I have no relationships to disclose. So I'm going to talk about an update on heart failure management, but to start with an update, I think we have to talk about where we came from. So let's talk about the old paradigm of heart failure management, where there's a stepwise approach to therapy based on symptoms. So class 1, no symptoms, ACE, ARB if you're ACE intolerant, beta blocker, with successive more therapy as symptoms increase. There's been 2 new exciting medicines in the past few years, now FDA approved for heart failure. There's Sacubitril, Valsartan. We're going to talk about its role as replacing ACE inhibitors or ARBs. And we're going to talk about Ivabradine and its complementary role to beta blockers. So we'll start with Ivabradine, but we'll start first with the beauty of translational medicine that is heart failure therapies. And it's really astonishing to me that an understanding of tiny molecules has led to therapies that help patients feel better and live longer. So to focus first on the sympathetic nervous system, initially beneficial. The failing heart gets more heart rate, gets more contractility, but ultimately maladaptive as this leads to ongoing hypertrophy, fibrosis, and heart failure, which is why beta blockers are so wonderful for heart failure patients. And the guidelines are very clear on this. Class 1 for all patients with current or prior symptoms of heart failure with reduced ejection fraction, bisoprolol, carvedilol, sustained release metoprolol. The guidelines are unequivocal because the trials are unequivocal. Trial after trial after trial. Less sick patients, really sick patients, post-MI patients, reduction in mortality. Well, you can't get much better than that, but there are subtleties to the beta blocker story. And one of the subtleties is that heart rate matters. So this is a subgroup analysis of a randomized trial of 5,300 patients, where they stratified patients based on their heart rate at study entry. So didn't even do anything to the patient, just said, what's your heart rate on entering the trial? What happens to you? And if your heart rate's over 70, increased risk of cardiovascular death, increased risk of heart failure hospitalizations. High heart rate, bad. Another interesting observation, if you take a meta-analysis of all the heart failure beta blocker trials, 23,000 patients, compare their heart rate at the start of the study with their heart rate at the end of the study, the more you lower the heart rate, the greater the mortality benefit. So low heart rate better, more heart rate lowering better. But I know what you're thinking. You're asking yourself right now, is this association or is this causation? Is the heart rate lower because patients are less sick, or are they less sick because their heart rate is lower? And it's really hard to tease this out with beta blockers alone because the titration is limited by the hypotension, the fatigue, the negative inotropic effects of beta blockers. So what if there is a medication that could lower heart rate without reducing contractility? Would patients do better? And that is the basis behind the rationale for Ivabradine. So let's talk about Ivabradine. So Ivabradine inhibits the funny current. Who says electrophysiologists have no sense of humor, huh? They called it the funny current. In the pacemaker cells of the sinoatrial node, it decreases heart rate without decreasing contractility. So the question is, would this medicine actually improve outcomes in heart failure? That was tested in the SHIFT study, Lancet 2010, 6,500 patients. They had to have a low EF. They had to have a heart rate above 70 because of these prior observations that was the magic number after which outcomes worsened. and they had to be on maximum tolerated beta blocker. That's important. There's this thing in medicine I like to call indication creep, where something is good for one indication that starts to be used for other slightly related indications that actually have no benefit. So Ivabradine was not considered a substitute to a beta blocker, because beta blockers are amazing. It was added on if the heart rate lowering was not able to be achieved with a beta blocker alone. And lo and behold, decrease in heart failure deaths and heart failure hospitalizations, which led to the FDA approval. And the package insert states that it reduces the risk of heart failure hospitalization, low EF, sinus rhythm, heart rate above 70, and emphasis added by me, maximum tolerated beta blocker or contraindication to beta blocker use. Side effects include atrial fibrillation, which is why the guidelines state you have to be in sinus rhythm to start it. And the other side effect is phosphenes. What are phosphenes? Bright lights in the visual field. Why would that happen? Well, it turns out that the other place where the funny current exists is in the retina. So the side effect can be bright lights in some patients. So that's Ivabradine. And now we're going to talk about my favorite new advance of the last 5 years, which is Sacubitril Valsartan. So let's go back to the beautiful triumph of translational medicine, which is our neurohormonal axis of heart failure treatments, and now focus, instead of the sympathetic nervous system, on the renin-angiotensin-aldosterone system, which again is initially beneficial. You have better blood pressure, more sympathetic tone for the failing heart, but ultimately maladaptive hypertrophy, fibrosis, worsening heart failure, which is why the ACE inhibitors in particular were a godsend for heart failure patients. And the guidelines are very clear. ACE inhibitors, back in 2013, Class 1 for all patients with HFrEF current or prior symptoms. Doesn't matter. Low EF, give them a beta blocker. Angiotensin receptor blockers based on the old guidelines. If you can't tolerate an ACE, be on an ARB. And the guidelines were so clear because the trials were clear. Now, this is busy. Of course it's busy, but because there's so many studies. But let's focus on Consensus, New England Journal, 1987. So 33 years ago, they took 250 patients with class 4 heart failure, only 250 patients, only followed for 6 months, 30% reduction in mortality. Do you know what the mortality in the placebo group was? 44% at 6 months. That's astonishing. Imagine a world where heart failure was truly a death sentence. And Consensus revitalized the heart failure community. They turned it into a disease with hope as opposed to none. And so, really sick patients, less sick patients, asymptomatic patients, post-MI, uniform reduction in mortality. ACE inhibitors, from 1987 onward, nothing could be better than an ACE inhibitor. The story with angiotensin receptor blockers is less clear, but clearly, compared with placebo, it reduces mortality and heart failure hospitalizations, but not better than an ACE. So how can you get any better than this? Well, let's go back to our neurohormonal cascade. So we talked about the sympathetic nervous system, we talked about the renin-angiotensin-aldosterone system, and both of those are maladaptive. Too much is bad, block them, better for the failing heart. But then there's the natriuretic peptide system, which is actually all good. More natriuretic peptides are better. Lower blood pressure, sympathetic tone, hypertrophy, fibrosis, more diuresis, wonderful. So you're thinking to yourself, a natriuretic peptide, that sounds familiar. There used to be a medication where you could give someone a natriuretic peptide. Yes. So if an increase in natriuretic peptides could help heart failure patients, but nasiritide, long defunct nasiritide, did not work, likely because it was a continuous infusion. So as soon as you turned it off, the benefit of the natriuretic peptides was no longer there. But another way to increase natriuretic peptides is to inhibit the degradation by neprilysin. And that's the rationale behind the neprilysin inhibitor Sacubitril. Sacubitril, by inhibiting neprilysin, will give the body a boost of more natriuretic peptides. But it's not Sacubitril, right? It's Sacubitril Valsartan. Why the combination? Well, neprilysin inhibitors alone don't work because neprilysin degrades other stuff. It happens to degrade angiotensin. So the neprilysin inhibitors increase angiotensin. So on one hand, good, more natriuretic peptides. On one hand, bad, more of the angiotensin that we talked about is maladaptive for the failing heart. Okay, so we have to combine the neprilysin inhibitor with something that will block angiotensin. Well, I just spent like at least a minute telling you how amazing ACE inhibitors were, angiotensin-converting enzyme inhibitors. So why isn't it neprilysin lisinopril? Wouldn't that make sense? Well, it would, except neprilysin inhibitor plus an ACE inhibitor is very bad. Why? Well, it turns out neprilysin also degrades bradykinin. So neprilysin inhibitors lead to more bradykinin. ACE inhibitors, as we all know, do. That's the ACE inhibitor-related cough. More bradykinin leads to angioedema. This was discovered through bitter experience years ago, and thus neprilysin inhibitors can never be administered concomitantly with an ACE inhibitor. So we know we have to combine this neprilysin inhibitor with something that will also block angiotensin. We can't use an ACE inhibitor, or the patient will get angioedema. What about a neprilysin inhibitor plus an ARB, and thus Sacubitril Valsartan was born. Now this was a very exciting time for cardiologists because it's not always that we get a brand new class of medications, and this is the ARNIs, the angiotensin receptor neprilysin inhibitors. Now I got through medical school largely through mnemonics and memory tools. So I'm going to give you one so you will remember this new class of medicine called the ARNIs. I tried to think of a famous ARNI that would stick in your mind, and the one that came to me was the former governor of the great state of California, so what you will not forget the name of this exciting new class of medications. So this is the pathophysiology behind why it should work. And in fact, this is the pathophysiology in action, the Paradigm HF study, which came out in August of 2014, 8,400 patients, and it was Sacubitril Valsartan versus enalapril. So it wasn't a placebo-controlled trial. It was a trial of Sacubitril Valsartan versus the reigning king of heart failure therapies that since 1987, nothing could knock off its throne. And a lot of people remember where they were when important things happened in history, space shuttle crash, Princess Di, dying in the Paris tunnels, depending on your interest and generation. But ultimately, I remember where I was when this study came out. So amazing was it to heart failure cardiologists. I was in an airport about to board a plane to Wisconsin for the Kittleson annual family vacation to the lake house with the family, when the table of contents of the New England Journal came up on my phone. And I said, a heart failure trial. It's probably going to be negative because the last time we'd had a positive trial in heart failure had been 2004 with AHEFT. So I'm like, I'm just going to read this abstract, then I can delete it, we can go on vacation. And lo and behold, I was transfixed by this figure because this was the first time since 1987 that any medicine bested the ACE inhibitor. Reduction in cardiovascular death, reduction in heart failure hospitalizations. So this was August of 2014, and it was July of 2015, 11 months later, that the FDA approved Sacubitril Valsartan to reduce the risk of cardiovascular death and heart failure hospitalization in patients with chronic heart failure and reduced ejection fraction. Now, the dosing is weird, right? It's 24-26, 49-51, 97-103. Why? Well, the FDA has this rule that if you have a combination pill, the milligram amounts of the two components cannot be exactly the same. So it's weird, but it's basically 25, 50, 100. It will cause more hypotension than an ACE inhibitor, not surprising. It's 2 vasodilators instead of 1, but less hyperkalemia, less rise in creatinine. BNPs are not accurate because it is increasing the body's endogenous BNP by virtue of inhibiting degradation by neprilysin. I don't find BNPs particularly helpful anyway, but if you want to follow that, you'll have to use NT-proBNP, which is likely more accurate. So that was August of 2014, the study came out. July of 2015, 11 months later, the FDA approves it. And 10 months after that, the ACCIAHA put out a focused update just to sing the praises of this new medication. And the new guidelines now tell us that ACE inhibitors or ARBs or ARNIs in conjunction with evidence-based beta blockers and aldosterone antagonists recommended for patients with chronic HFrEF. But they go on to say that in patients with chronic symptomatic HFrEF who tolerate an ACE or an ARB, that replacement by an ARNI is recommended to further reduce morbidity and mortality. So the guidelines are very bold and have drawn a line in the sand that ARNI is the best. ACE inhibitors are second best, and ARBs are third best. So there's not much as a heart failure cardiologist I can do that's dramatic. I don't cut people open. I don't put fancy structural things inside their heart like I'm playing a video game. But there is something I can do that's amazing. I can give a patient a pill that will actually save their life, and that matters too. So when we think about, and then the class 3 is important. What are the contraindications? Don't administer concomitantly with an ACE inhibitor or within 36 hours. Don't administer to patients who have a history of angioedema because of this risk of increased bradykinin. I think 36 hours is weird in clinical practice. I just tell patients 2 days works practically. So, and Ivabradine was also added to that update class 2A, which is similar to the level strength of evidence that Digoxin has, beneficial to reduce heart failure hospitalizations. But remember that it has to be if you meet the criteria of symptomatic low EF, heart rate over 70, max tolerated beta blocker, so that you don't have indication creep. Use it in the patients in whom it's been shown to be beneficial. So I've talked to you about the Paradigm trial, and I talked to you about the Shift trial, which, if you will permit me, gives us a paradigm shift in heart failure. So I told you about the old paradigm, and the new paradigm is ARNIs now first line for patients with heart failure, and Ivabradine can be added on for those symptomatic patients with the caveats we mentioned. So in the time we have left, I'm going to touch on the other really important medicines we need to think about for patients with heart failure. We shouldn't forget about spironolactone, isodilhydralazine, digoxin. So spironolactone, the guidelines tell us if you have symptomatic heart failure, take spironolactone. Class 3, contraindicated if you have bad creatinine or high potassium. So let's talk about why the guidelines say these things. So the trials are pretty clear. Less sick patients, post-MI patients, reduction in mortality. But this observational study in the New England Journal in 2004 is really important because it is a cautionary tale. What the authors did is they took the prescription claims data and hospital records for patients above the age of 66 in Canada, basically their Medicare database, and they compared 2 time points, 1994, before anyone had ever heard of using spironolactone in heart failure, and 2001, where they figured use of spironolactone would have trickled into clinical practice. And they compared spironolactone prescriptions, hyperkalemia hospitalizations, and hyperkalemia deaths. Now, this is purely observational and cross-sectional, but between those 2 time points, spironolactone prescriptions went up, hyperkalemia hospitalizations went up, and hyperkalemia deaths went up. This is a really good example of the dangers of indication creep. In the clinical trials, all these heart failure patients started on spironolactone had normal creatinine and very close monitoring of their potassium. In clinical practice, especially these older patients whose GFR was not going to be normal despite perhaps a reasonable creatinine, there could be a risk of heart failure, risk of hyperkalemia deaths. So it's a good lesson in making sure the medication you're giving is in the right patient that follows the clinical trial criteria to avoid untoward effects like this. So the bottom line with spironolactone is watch the potassium, and then a word about eplerenone. It's more expensive. Really, the only benefit would be if someone has gynecomastia on spironolactone, choose the eplerenone. Now let's talk about isodilhydralazine. Class 1, indicated in patients who are self-described as African American with heart failure symptoms on optimal therapy with ACE and beta. Class 2A, you can consider it instead of an ACE inhibitor. So this is another example of do not succumb to indication creep. Just because someone is African American doesn't mean you grab the isodil hydralazine. You grab the ARNI ACE ARB beta blocker first. It's only in addition to. And if we look at the studies, so the oldest study I'm going to talk about today was not actually Consensus, which came out in 1987, but VHEFT1, which came out in 1986. And this is an interesting study because let's look at this. They took low EF patients and randomized them into isodil hydralazine prazosin or placebo. Prazosin, an alpha blocker? What, did these patients have BPH2? What was going on? So the reason they did it is back in those days, the gurus of heart failure knew that afterload reduction, vasodilation would be really good for heart failure patients, right? You take that poor or failing heart, you reduce the resistance it has to pump against, and of course, cardiac output's going to go up. But they didn't know how they should reduce afterload. Should they do it with isodil hydralazine? Should they do it with prazosin? They didn't understand initially the neurohormonal underpinnings of why ACE inhibitors were good beyond the hemodynamic benefits of afterload reduction. They got lucky, which is good for all of us. But back then, of course, prazosin failed, and we never heard about it again. And VHEFT was exciting, and the raging debate in the mid-'80s was, should it be an ACE inhibitor, should it be isodil hydralazine, though Consensus and VHEFT2 pretty much answered that question. And between 1991 and 2004, pretty much everyone forgot about isodil hydralazine. It was relegated to the dustbin of heart failure history until AHEFT came out. And this was pretty extraordinary, that you take patients self-described as African American with severe heart failure, and you have a dramatic reduction in heart failure deaths, heart failure hospitalizations, and quality of life. But an important point is note that the entry criteria, patients had to be on an ACE, ARB, or beta blocker. There was no ARNI, of course, back in 2004. But it's not as good, clearly, as ACE, ARB, ARNI. You don't give it instead of, it's only in addition to. Now, what's the mechanism? Is it antioxidant, nitric oxide donors, blah, blah, blah? No one knows. Could it just be as easy as hypertension? If you look at the baseline systolic blood pressure in AHEFT, it was 120. How many heart failure patients do you take care of with an EF less than 35% with class 3 to 4 symptoms who have a systolic blood pressure of 120? Very few. This is a unique population that patients who are African American with heart failure tend to have hypertensive disease, and so it could have boiled down to just better control of blood pressure. That being said, remember, it's not a substitute, it's an addition once you've maxed out the agents that truly improve mortality compared to placebo. And finally, digoxin, poor digoxin. No one likes digoxin. Class 2A can be beneficial to decrease hospitalizations for heart failure. It all boils down to the digoxin trial, the DIG trial in 1997, where 6,800 patients were randomized. There was a reduction in heart failure hospitalization, but no change in mortality. But note the median dose of digoxin in that trial was 0.25 milligrams daily. That's a high dose. I can't imagine many of you give that much digoxin anymore. So 2 subgroup analyses shed light on this. One looked at digoxin levels and found that if your level was low, there was actually some mortality benefit. If your level was high, you had increased mortality, so the trial as a whole was probably a wash because of this interaction between the levels and survival. You know, no one's ever going to do another trial with digoxin, and you can also argue that our other therapies are so much better that maybe we won't need it anymore, and maybe the updated guidelines will really downgrade its strength of evidence and level of recommendation. But ultimately, I think don't forget about it. If you've got a patient who's hospitalized a lot, and their creatinine's okay, and you've tried everything else, it certainly can't hurt to think about digoxin. So, I was supposed to talk about an update in heart failure management. And I've told you all the exciting things about the 2 newest FDA-approved medications for heart failure. I told you about Sacubitril, Valsartan. told you about Ivabradine, but I know what you're all thinking. Again, I know. You're saying, aren't you going to talk about the SGLT2 inhibitors, the newest, most exciting advance in heart failure since Paradigm HF? And it's, like I said, it's very exciting because it was 2004 to 2014 where we had a desert in heart failure. There was nothing exciting going on. And now there's so much exciting going on, we can barely hold it all in. So sodium glucose cotransport 2 inhibitors, no one really knows how they work. It's highly mysterious. But if you put all the highly mysterious putative mechanisms into a flow chart, it looks very official. So it reduces oxidative stress, fibrosis, inflammation, with effects on the kidneys and effects on the heart. And where this all began actually was, we all know the danger of surrogate endpoints, right? Just because an antiarrhythmic reduces PVCs doesn't mean it's going to save your life. And similar things were happening in the world of diabetes. Just because you could lower the hemoglobin A1C didn't mean that diabetics getting a diabetic medicine were having a less risk of heart attacks, which is what we really care about. So the FDA said enough's enough. We need some hard endpoint trials in diabetes, and the clinical trial architects complied. And then came many trials of these SGLT2 inhibitors, Empareg, Canvas, Credence, Declare Timmy 58, empagliflozin, canagliflozin, dapagliflozin. And how wonderful. You took diabetics at high risk of atherosclerotic disease, and you gave them one of these SGLT2 inhibitors, and hooray, cardiovascular death, MI, and stroke was decreased. But then there was this unanticipated, mysterious, reproducible effect of a decline in heart failure hospitalizations. These weren't even people who had heart failure. These are just diabetics who also had hypertension, high cholesterol, your typical setup for coronary disease. And so that led the clinical trial wizards to say, wait a minute, maybe we should just test this medicine in heart failure patients. Let's forget about this whole diabetes thing it's supposed to be good for. And that was the rationale for the DAPA-HF study, which took low EF patients, symptomatic, high BNP, just to enrich the population with higher risk for sample size considerations. Only half had diabetes, and they randomized them to dapagliflozin versus placebo. And then, again, I actually remember where I was when this trial came out as well. It was presented at the European Society of Cardiology meeting in August of 2019. I was not in Paris at the meeting in person, but I was on Twitter, so I was very excited to see this trial. And in fact, again, absolutely astonishing that on the background of amazing medical therapy, you could have a decrease in hospitalizations of heart failure by 30% and a decrease in death from cardiovascular cause by about 20%. So it's a very exciting new time for heart failure with all these various disparate mechanisms converging to help people feel better. And, but is that all there is? Come on. Nothing else exciting going on? Okay, one more thing. One more exciting new medication to tell you about. And that, just 2 days ago, the American College of Cardiology published the late-breaking clinical trials that would be presented in Chicago at the end of March at the annual meeting. And one of those is the Victoria trial, very CGWAT, in patients with heart failure and reduced ejection fraction. Very CGWAT, very exciting. So, Vericiguat is a soluble guanylate cyclase stimulator. And I've never heard of that before. No, it's yet another brand new class of medications in heart failure. So much exciting stuff to keep track of. What does it do? Okay, we all know that oxidative stress is bad, inflammation is bad, endothelial dysfunction is bad, nitric oxide is good. This fancy new molecule acts independent of nitric oxide to stimulate this soluble guanylate cyclase to get more cyclic GMP. Cyclic GMP, very, very good, we all remember from our biochemistry classes, and to reduce myocardial dysfunction and vascular dysfunction. And you could say to me, but wait a minute. You told me the Victoria trial results weren't going to be presented until March 28th. Why are you bothering to tell us about a trial where we don't even know what the results are? Well, we can thank the healthcare economics for that, in that there is a rule that if the results of a trial are available, they must be publicized, the bottom line results, as soon as they're available, in order for shareholders to know, even before the science is presented. So, I've been waiting for this since November, actually, because November 21st, 2019, there was a news flash that the investigational drug Vericiguat reduced the risk of heart failure hospitalization in the Victoria trial. So remember, you heard it here first, or maybe you also were on Twitter on November 21st, 2019. But regardless, keep your eyes peeled. There's more to come with yet another class of heart failure medications. So we can save a lot of lives. Like I said, I'm not some fancy interventionalist. I wish I were. I just don't do well when blood is spurting. I do much better when I can think methodically in my office. But you can still do a lot of good. If you add an ARNI, a beta blocker, an aldosterone antagonist, an SGLT2 inhibitor, you get increasing benefit, reduction in mortality. You can take someone who has a 1 in 3 chance of dying in the next year and reduce that dramatically. It's so easy to do, and it can make such a difference. And we're ushering in really a foundation of a new era of quadruple therapy in heart failure. This comes from an editorial by Mike Felker at Duke. It just came out last month in Circulation, based on the amazing SGLT2 inhibitors and adding them soon to our armamentarium once approved by the FDA. But I would say that with Vericiguat now, we're thinking more about 5 Alive. So again, you heard that here too first, but I anticipate within the next year or two, as these medications are approved by the FDA, we'll have increasing standards of what we will need to give to our heart failure patients to make them feel better and live longer. So we talked about the paradigm of outpatient heart failure management, and currently in 2020, this is where it stands. But I anticipate in 2021 or 2022, we'll be adding dapagliflozin as well as Vericiguat to our management of heart failure patients. And I want to thank you so much for your attention.
Thank you so much, Dr. Kittleson.